probably in all published data, around 5 to 10% of patients undergoing renal transplantation had this type of rare kidney disease. However, they are very peculiar because they have a very high risk of recurrence after renal transplantation, one of the highest with atypical HUF. While all other glomerular disease or non-glomerular disease do not have such high risk of recurrence and such high risk of loss of the kidney graft due to the recurrence. That's what makes them very special. The second point is that they do not have any specific efficacious disease treatment, whereas all the other glomerular disease that may recur after kidney transplantation has to some extent some efficacious treatment already used in native kidney. That's why C3G and immune complex MPGN patients used to have a double burden. They had a burden because they had no treatment for native kidneys, and they had no treatment for potential recurrence and severe recurrence in kidney transplant. What we do usually is, of course, antiproteinuric and nephroprotective drugs with ACE inhibitors, the usual stuff, and you add SGLT2 inhibitors more recently. And what we do is MMF, microphenolate mofetil, and corticosteroid as first line. With more, this based more on retrospective data than prospective control data. That's why renal transplant have already more or less the first line treatment because they already have usually MMF and to some level corticosteroids and to some level even CNI or mTOR inhibitor. That's why it makes it more tricky to treat recurrence in kidney transplant. The major point, in my point of view, is that the disappearance of C3 deposits in roughly 80% of patients is still sustained at 52. And this is the first time we see in such a clear demonstration based on immunofluorescence and electron microscopy studies that a significant proportion of patients have a reversal of C3 deposits, something never seen before, including with MMF, corticosteroid, or all the previous, which means that for once we are targeting the main driver of disease, which is C3 deposition. And this is the major finding. And on top of this, you have also reduction in inflammatory changes in kidney transplant and reduction in proteinuria for patients who had initially proteinuria. So you have a combined picture with C3 going down, deposition going down in the kidney transplant, inflammation going down, and proteinuria going down with preserved eGFR. But the first clear demonstration of reversal of deposit, which was sometimes very impressive in some patients, is the best good news we can get for patients. So the design is more or less the same. The primary endpoint is different. The primary endpoint in the Valiant is proteinuria, reduction in proteinuria, whereas in the Noble, it was mainly, primary endpoint was reduction in C3 deposition. But the Valiant study will give in a larger picture, a larger number of patients, more than 120 patients, which is a very significant number for such a disease, will give a more clear idea, or in my point of view, they will confirm the previous data in kidney transplant and extend them hopefully to native kidney patients based on proteinuria as primary endpoint. But as you said, the Valiant study included patients with native kidneys and transplant with C3G and immune complex. So there were probably some sort of certification to see what subgroup, what is the effect in each subgroup of these patients. C3G versus immune complex, native versus renal transplantation. I think the demonstration of the reversal of C3 deposits is, in my point of view, one of the best demonstrations that we have probably finally a disease-specific, targeted, efficacious treatment. Because In all glomerular disease, we assume that immune deposits are creating the disease. Here, the main deposit is C3 in C3GN, and in immune complex MPGN, it's still debated if immunoglobulin deposits add something to the pathogenicity of C3. But in all cases, the data from the Noble study give us a lot of hope and the sense that we have finally a specific targeted efficacious treatment for C3G and immune complex MPGN. And the Valiant study will help us confirm this result so far.